Hi everybody, I'm Dr. Mark Greenstein. I'm a urologist here with Advanced Urology, and today we're going to talk about a procedure that is kind of new to America called aquablation. So this is mostly for prostate enlargement, and let's take you through the slides. So once again, my name is Mark Greenstein. I am a board-certified urologist here in Atlanta. I joined Advanced Urology about 2 years ago after practicing in New Jersey for about 15 years. I've done all kinds of different prostate surgeries over the years: needle ablations, TURPs, lasers, microwaves, urolifts, resumes, prostate cancer surgery, open, robotics, and now I'm one of the adopters of this new technology called aquablation. So the goals of this presentation are to address the following questions. What is BPH, or benign prostatic hyperplasia? What are my treatment options, and who and why should I consider aquablation therapy? So let's go through the anatomy here, understanding what BPH is. So the prostate is this little gland that lives under your bladder. You're not even supposed to know that it's there. The only job of the prostate is to make children. That's it. It provides fluid for the sperm, so that the sperm can get to the cervix, and then they can get into the uterus to make children. After that, the prostate's job is to cause problems: enlargement, pain, bleeding, infections, and of course we worry about cancer. And then its job is to give me something to do, otherwise I'll be bored all day. So prostate enlargement happens in almost all men, some young in their 40s, a lot of guys as soon as they hit 50, and it's going to affect at least 50% of the population. And each year, as you can see in the diagram, we have the prostate underneath the bladder here. This is the tube that we urinate through called the urethra. And as the tissue of the prostate grows, it crunches down on the bladder neck, it crunches down on the urethra, and the bladder starts to get thickened because the bladder's a muscle. And then we start having, trouble urinating. No one knows why that the prostate enlarges. It's mostly genetics. It's part of the gene pool. So if your dad, uncle, grandfather has it, you're most likely going to have it too. So what are some of the symptoms of benign prostatic hyperplasia? Well, the first is the inability to hold in your urine. In other words, all of a sudden, you're going to start getting some urgency. You're going to get frequency. Urgency is where we get the immediate need to run to the bathroom. Frequency is like, oh my God, I got to go again. Nocturia is the worst because that's when you're waking at night and you got to get up and you start losing sleep. And then of course, the embarrassing part is the little bit of the dribbling that happens when you're trying to get to the bathroom, or even sometimes after you go to the bathroom. Then there are symptoms of you can't empty your bladder well. That's the obstructive symptoms. So that's straining or the need to push. Sometimes it burns. Sometimes there's some hesitancy. In other words, you go to the John and you're standing there, you're like, oh my God, okay, here we go. Let's get started. Oh, finally. The weak stream, the stream should be nice and strong. Some guys are starting to tinkle on their toes. Intermittency or stuttering, the stream starts and stops. And then of course we worry about the big one of urinary retention. In other words, one day you just can't pee. You stop peeing. You wake up, you're like, oh my God, I can't urinate at all. You're running into my office or you're heading into the emergency room. What does this all do? It affects quality of life. Lack of sleep, lack of going out. You need to find out where all the bathrooms are. Some guys need to take a change of clothes with them. And then the intimacy of leaking or bladder problems during sexual activity. So how do we diagnose benign prostatic hyperplasia? Well, you go to your family doctor or you come to a urologist and we talk to you. What are your symptoms? We're going to ask you to fill out a questionnaire called the International Prostate Symptom Score. It is a validated study or questionnaire that helps us go through all of those symptoms that we just discussed. Of course, we're going to examine you. This is the digital exam. This is where we have to put our finger in a place that the finger doesn't belong, and that's where we're going to feel your prostate. A lot of times we will also check a urine sample. We'll have you pee in a cup. We do a dipstick to see what's in the urine. We will do a bladder scan. That is like a mini ultrasound where we check how much is left over in the bladder after you've gone to the bathroom. We call that a post-void residual. And a lot of times we'll do a flow study. That's literally you pee into a funnel or you urinate into a funnel, and it records how fast it comes out. Is it coming out at high speed? Is it coming out at slow speed? And those are some of the basic tests that we do. I'm going to back up a second here. Some of the other tests that we'll do, depending on the person, is we will measure your prostate. We'll do an official ultrasound to look at your kidneys, to look at your bladder. We like to look at the bladder wall thickness because the bladder is a muscle. You work the muscle hard, the muscle gets thicker. And actually in bladder life, that's not a good idea. We don't want a thickened bladder like you want your muscles. We will measure your prostate under ultrasound. How big is it? Prostate should be a walnut, should be that big, 20 to 30 cubic centimeters measured. In other words, length times width times height. Whereas some guys come in and they got these monsters. I saw a guy today, 200-gram prostate. Saw a guy earlier today, 110-gram prostate. Yesterday, 90-gram prostate, 60-gram prostate. It comes in all shapes and sizes. We will also do pressure testing. We want to know how much pressure is being generated in the bladder to urinate, because a bladder that's working real hard is a bladder that's going to not work later if we don't treat it in time. And the last thing we want is a patient to come in and their bladder has given up. That's always hard to handle. Think of it like this. Everybody's heard of congestive heart failure. Congestive heart failure is where the heart is beating so hard that eventually the muscle starts to weaken and the bladder, and the heart starts to fail. Well, we see that in the bladder. The bladder starts to work hard, the muscle thickens, and then eventually the muscle of the bladder gives out. So what are some of the treatments? Well, we have watchful waiting. Let's just watch, sit tight. Maybe take some over-the-counter stuff like saw palmetto. There's medications. It's America. We love medications. Flomax, uroxetrol, Solodicin, finasteride, dutasteride, terazocin, doxazocin, all kinds of medications to relax the prostate or shrink the prostate or both. And then there's surgery. The main surgery, the gold standard surgery, is what's called the prostate resection or TURP, also known in the locker room as Roto-Rooter. Everything in the world of prostate enlargement is based on the TURP because that's all that there was for about 40 years. And then medicines were invented. And medicines kind of stifled the world of prostate surgery. But still, there are guys where medications just don't work. And then as life went on, starting in the 80s, different surgeries were invented to mimic the TURP or resection of the prostate. So watchful waiting means we're just going to sit tight. Your urine symptoms are not that bad, but your prostate's getting a little enlarged. So for example, let's pretend you're 52 years old. I measure your prostate. It's about 35 cubic centimeters. But your symptoms are annoying. They're not ruining your day. You're not having any trouble. We're just going to sit tight. Maybe bring you back once a year, every 6 months, check your symptoms, check your residuals, check your urine, et cetera, et cetera. Then there's medications. Let's shrink them. Let's relax the prostate. Let's shrink the prostate. So like I mentioned, tamsulosin, which is Flomax, Solodicin, which is Rapaflo, uroxetrol, which is alfluzicin. Those are some examples. Those relax the prostate. And so the prostate's a gland. It's got little muscles inside of it. And those muscles relax. The bladder squeezes better. They empty bladder better. And the symptoms start to get better. And then there's the finasteride and dutasteride. Those are medications that shrink the prostate. And in some studies, they'll shrink the prostate by 30%. Ideal in a patient where they have a 50-gram prostate or 50 cubic centimeter prostate. Not ideal when I have a guy that brings me 130-gram prostate or 130 cubic centimeter prostate. Because 30% of 50 is very different than 30% of 130 cubic centimeters. The other problem with medications is you got to pay for it. You know, some of the insurances give a stifle to that. They don't pay for some of these medications, and medications have side effects. Tamsulosin and silodosin cause dizziness, they cause loss of ejaculation, and they're also linked with dementia. So we don't like those medicines too much for the long term. Finasteride and dutasteride, great medicines, shrink the prostate. They will even cut your PSA down in some individuals, but linked with breast enlargement, loss of libido, loss of ejaculation, tiredness, lack of sex drive, which is loss of libido. And in some men, we can throw the kitchen sink at them with the medications. And like it says here, up to 30% of men will not do well with medications. So then there's surgery. And like I told you, surgery has been out there for years. It is there to make the prostate smaller, open the channel. And so everything is built on the roto-rooter, the TURP, as it mentions down here, the resective surgery. A TURP is where I look inside a bladder, of course under anesthesia. I have a camera called a resectoscope, and I basically carve out the inner part of the prostate. My analogy is take an orange, the rind is the capsule of the prostate. Make a hole in the middle, and then take your finger and just scrape out the pulp in the middle of the prostate. That's the prostate enlargement tissue that I scrape out, and you leave the rind behind. So now you have a big channel to urinate through. That's a TURP. And so what's been invented over the years are things like a Urolift, something called steam therapy, which is a Resume. There's all kinds of laser surgeries, Revolex, Holep, green lights, and those are just to resect the tissue, but using laser technology as opposed to a resective or electricity technology. Another tried and true is something called a simple prostatectomy. Now, that's also been out for many, many decades, but that's a bigger surgery. That is sometimes requires an incision from the belly button down to the pubic bone. That's where we open the belly up, and we basically take out the middle of the prostate with my hands. Every urologist will tell you stories about doing a prostatectomy because it's actually a fast operation with great outcomes, but you're in the hospital for a while. You may have to have a transfusion because it tends to be a bloody surgery. Recently, in the last 10 years or so, if not a little bit longer, they're able to do this robotically now, but it still requires abdominal surgery. It's got a different side effect profile because you're involving the belly now. Still a great surgery, but not for everybody. So what about aquablation? So a company called Procept came out and said, let's think outside the box. Let's find some other way to treat these prostates that are enlarged and causing obstructive and irritative symptoms. And they invented aquablation. So it is a type of resective surgery because you're getting rid of the blocking tissue. You're not moving it, you're not lifting it, but you're resecting it. It uses water jet therapy. So in other words, everyone knows what it's like to, well, not everyone, but a lot of people know what it's like to power wash a deck. You go to Home Depot or Lowe's, you rent a power washer, you hook it up to electricity, you hook it up to your water source, and you just power wash your deck, your patio, your driveway, and it gets rid of all of that nasty stuff that's sitting on your driveway or your patio. And so what aquablation does is it uses ultrasound-guided robotic technology that is basically like a GPS. I tell it exactly where to go, and it uses this water jet therapy to vaporize that tissue and literally scatter it into basically like a dust. So I'm going to show you a little video here that talks about how aquablation is performed. And so just so you can understand the beginning of the video, it's ultrasound guided. So this is the ultrasound in the rectum. This is the prostate right here. This is the bladder over here. This is the specialized aquablation cystoscope or camera that has a lens and has the water jet therapy. And let's see if we can find a way to make this turn on. All right, so we'll use my little finger pointer now. So this is a gentleman, it's a cartoon, but here's a gentleman that's asleep. So it's done under general anesthesia. They're placed in what's called the thotomy position. That's like when the baby's delivered. The ultrasound is placed into the rectum, and I start mapping the prostate. And here's my ultrasound up here in the right corner. The camera goes in, as you just saw, into the penis and then into the bladder. And then I start playing basically a computer program, and I start mapping the prostate. So this is the prostate here. I tell the device where to go. I make sure that all points are looking good. We test the water jet. We tell the computer program where the camera is, so that it's, like I told you, GPS guided. And then once we're a go, we turn on the water jet therapy. This is just some more, this is a side view. So the prostate is here. Actually, excuse me, the prostate is here. Prostate's here. And then this is me telling the device exactly where to go to the millimeter. And it's telling me where the opening of the bladder is, the prostate growing into the bladder, because that's very common. And then I step on a pedal, and here comes the water therapy. And so here's a schematic or a diagram, a cartoon of what it looks like. In the lower quadrant was what it looks like under ultrasound. This is what it looks like with my camera, and you can see the jet therapy going from side to side. We drain the bladder off the side, and we wait for the water jet therapy to get to a specific point in front of the prostate. And so the end point here is actually where the ejaculatory ducts are for ejaculation. And so we can spare this part of the prostate so that ejaculation can get spared in many of the patients that we do this aquablation for. So once we're done, camera comes out. Ultrasound comes out. And then what I do at the end, or what we do at the very end of aquablation, is then we put a resectoscope in, and we actually get some of the, what we'll call it, vaporized tissue out of the way. So I have to actually go in and kind of scrape some of that tissue out of the way. We want to do some pinpoint cauterization, because everybody in every prostate surgery, no matter where they are, who they are, what doctor they have, they're going to have some bleeding. It's just part of the procedures. And so afterwards, when we're done, we put a camera in, we get some of the fluffy or vaporized tissue out, we cauterize the area, and then we put a specialized catheter into the bladder called a three-way catheter. This is where we start irrigating the bladder. And so they're going to wake up from anesthesia. There's going to be a catheter in their bladder. There's going to be big bags of fluid over here that drip fluid into the bladder and then drain right out. And what that does is it helps control bleeding in aquablation patients, or any patient with prostate bleeding or bladder bleeding. All right, so why aquablation? And so one, it's GPS guided. In other words, I am seeing exactly where to go because I know the anatomy based on the ultrasound that is live in front of me. So I say here, 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 and I don't have to worry about going to different areas. It's robotically controlled. In other words, I'm telling it where to go, and then the machine does the work for me. It's almost like being on a factory and you have a robot saying, okay, time to put a hubcap on this car. And I can control all that. And if I don't like the way things are going, I take my foot off the pedal and I make it better. The long-term data is pretty good. Actually, it's very good, excuse me. The patients that we've done here at Advanced Urology are doing great. They are very happy. Sexual experience has been good after surgery. Everybody's off their prostate medicines unless they need to take something long-term for another reason, and we can talk about that in a second. but the durability has been superb. So after the procedure, you're going to wake up. There's going to be a catheter in. We leave that in overnight in the hospital. The average stay for patients in our practice here is 1.6 days. In other words, most people go home the very next day. Some people have to stay an extra day because of either blood pressure management, sugar management, catheter management, whatever they need to do before they go home. Patients' catheters are coming out usually about 2 or 3 days after their surgery. So classically in my practice, what we do is you go home with the catheter, you just get better. The nurses and my staff will teach you how to handle the catheter. It's actually not that bad. It's annoying, but it's not that bad. And then we're going to bring you into the office, usually about 2 to 3 days after the surgery. We're going to fill your bladder up with water right through the catheter. We slip the catheter out and we get you to urinate before you go home so that we know that you're doing well. Of all of the patients we've done, no one has had to have the catheter put back in, so that's a bonus. And then, once the catheter comes out, you just have to get better. Everybody's a little sore. Everybody has a little bit of bleeding. Everybody has urgency and the need to go to the bathroom a lot, because when you operate on the prostate, its next door neighbor, the bladder, gets upset and it says, let's go to the bathroom a lot. Usually I have people taking it easy for about 2 to 3 weeks after surgery. We just don't want you to do anything dumb. We don't want you to go and ride your bike. We don't want you to go and play golf too quickly, because we want you to heal. The last thing we want to do is have to bring someone back to the operating room for bleeding or for pain, or give them extra pain medicines when we really can avoid things like that. So that's basically my talk on aquablation. We're thrilled about it here at Advanced Urology. We've been doing it for the last about 1.5 years, if not 2 years already. And we think it's got a great future in the world of prostate management. And so what I'd like to do now is I'm going to open up the little chat room here for some questions. So give me a second here. All right, so our first question is, what's the catheter time? So like I mentioned in one of the previous slides, the catheter times are usually catheter definitely overnight. Everyone has a catheter for a minimum of 48, if not 72 hours. In the study that we did here, we studied our first bunch of patients, and I think we had some patients where the maximum catheter time was about 5 days. But almost everybody's getting a catheter out in about 48 to 72 hours. And like I said, the catheters are annoying. My staff will help you with it. We'll give you medicines to calm down the irritation from the catheter so that everything gets better. Next question, hospital time. Like I mentioned before, everybody stays in the hospital overnight. It's just what we have to do. 1.6 days of hospital stay. So when we looked at our studies of our patients, 1.6 day of hospital stay was the average. In other words, almost everybody was going home the next day. Some people needed to stay an extra day because of nausea or sugar management or high blood pressure, or just they needed an extra day of irrigation. Sometimes that happens. Hopefully that answered your question. Next question, size of prostate. All right, so this is where this is important. So for the last 18 years of practice, I have always, and I mean always, determined the type of surgery that a patient needs based on size. I am not a one-trick pony. Not everybody in my practice is going to get aquablation. Not everybody's going to get a TURP. Not everybody's going to get a UroLift or a Resume. I tailor it to the individual. Now, in Europe, where they have done aquablation longer, because everything starts in Europe, they've done this on all different kinds of sizes of prostate. 50 grams, 40 grams, 150 grams, all different walks of life. Presently in my practice, I'm reserving aquablation for prostates that are very big, 90 grams or higher, 90 cubic centimeters and higher. The reason for that is because when prostates become 90 cubic centimeters and higher, those men have higher complication rates when you do a scraping of the prostate or the TURP. There is an old school side effect called a TUR syndrome or transurethral syndrome. In other words, when I scrape the prostate, I am causing veins to open in the prostate. And when I scrape the prostate and do prostate surgery, I'm using irrigation to see where I'm going. That irrigation can get into the venous system. If that irrigation gets into the venous system too long or too much, a person's salt levels will drop. If their salt levels drop, they can get very sick. And so the bigger the prostate, the more the resection. The nice thing about aquablation is I'm done in 45 minutes. The resection time is anywhere from 4 minutes to about 10 minutes. And so the chances of this side effect, this TUR absorption or TUR syndrome, is practically zero. And so that's why when we have a prostate that's really big, I think this is a great approach, because the alternative is open surgery, like an open simple prostatectomy, or a robotic simple prostatectomy. Still great surgeries, but now you've introduced more side effects into the type of surgery, because you have to open the patient up or put laparoscopic cameras in. The other thing that I've done for people is multiple TURPs. In other words, let's say I have a 85-year-old guy that brings me a very big prostate and he can't urinate. Well, I'm going to scrape him out, let him heal up, scrape him out again, let him heal up, scrape him out again, because there's only so much I can do in about an hour's worth of surgery, because it's that hour mark where the risk of the absorption of saline, the absorption of the fluid that we use, causes that TUR syndrome. Now, I could do multiple things. I can do other things, like I could resume a person and do steam therapy, but it's just not going to be as definitive as something like aquablation. And that's why I think aquablation has its role for prostates that are super large. And I hope that answered your question. All right, next question. What if someone has had previous prostate surgery? All right, so great question. So unfortunately, the prostate likes to grow back. I can do the most perfect surgery in the world. I can get out all the little parts of the prostate and just leave that shell behind, but that prostate's going to try to grow back. Some guys, it will grow back within a few years. Some guys, it'll take 20 years, but it's going to try to grow back. So let's say a person had a resume previously, or they had a urolift previously, or a green light laser previously. Well, if I look inside their bladder and I do my ultrasounds and I still see a very large prostate, they are definitely a candidate for aquablation, because it will get rid of all that residual tissue, or that tissue that regrew or grew back. If someone had a urolift, which is those little clips that go in, it'll get rid of those clips and I'll just flush them out of the bladder when I'm done. Next question is, what about ejaculation? So like I said, this is probably the only surgery out there that is with a camera, that is resective, that can spare the ejaculation. Why? Because when I showed you that map, or that video of the prostate, and I map it out, it is showing where the ejaculatory ducts are. And I can tell the ultrasound, the robotic technology, to spare that area, to spare those ducts, so that the ejaculation is saved. And let's be honest, when you have a man who is very in tune with their sex life, they're going to want to make sure that their erections and their ejaculations are spared with prostate surgery. The last thing I want is to have a patient who's very upset because their sex life is very different after having prostate surgery. Next question. Erections. What will my erections be like? Well, the other nice thing about this technology, like some other technologies, that it should not affect the nerves that head to the penis to help you get an erection. And so those nerves are underneath the prostate, and because there's no heat or energy that's involved, those nerves should be spared. So the erection should be fine. The other thing is, we're not going to disrupt the blood supply to the penis at all. And so if the blood supply to the penis is good, that's all that matters as well. Those should be spared, and the erection should not be involved and should not be harmed with aquablation. Let's see, next question. Question about prostate medications. Well, almost 100% of guys are going to come to me on their prostate medications because that's usually the first line of therapy. If they're not on prostate medications already, I'll tune them up with prostate medications like Flomax and finasteride at the same time. But then after the surgery, we'll get you off your medications, because why take something that brings risk for the long term when you don't need them after the prostate has been opened up and the channel's nice and big. Now, with that said, I will keep some men on finasteride. And there's two reasons. One, there's some men I do not want back in the operating room ever again, because I don't want them to have the risk of anything with anesthesia, with catheters, with hospitals. And so if I can prevent the regrowth of that tissue, I'm going to do that. And that's where finasteride comes in. The other group of men are men that have had a risk of prostate cancer. So they haven't had prostate cancer. They've had a risk of prostate cancer. So for example, they had an elevated PSA, their father had prostate cancer, but they've been worked up and they don't have prostate cancer. In the prostate cancer prevention trial, it has showed that there is a role of keeping men on finasteride to prevent prostate cancer from developing. So in some men, I will keep them on their finasteride because it has a role in prostate cancer prevention. And I hope that answered your question. Last question is, will my prostate grow back? Well, unfortunately, I can't fight genetics. I can't fight DNA. And yes, your prostate will grow back. But I'm hoping that this is a surgery that's going to last you 10, 20, 15, who knows, years. The problem with any prostate surgery is we don't have data that long. We have anecdotal data. In other words, I can interview a urologist that started practicing in 1980 and ask him what prostates or what patients that they operated on in the 80s have required secondary prostate surgery. And they're going to tell you there's a lot, because after TURPing or after aquablation, after aquablation, after resumes, after laser therapy, that prostate's going to try to grow back. But we do our best to try to keep it at bay, prevent it from growing back as fast as possible with keeping an eye on you. We bring you into our office, we check your residuals, we check your flow. Some guys need to jump onto prostate medicines again, but hopefully it will be a long time with the surgery that you receive. And I think that is it for questions. So I'd like to thank the ProSet people for Aquablation for helping me put together this little talk. I'm personally fascinated with the technology. I think it has a wonderful future for treating men, specifically men with very large prostates. And then we'll see, maybe we can start diving in and helping guys with some of the not so large prostates or medium-sized prostates, but also want to have a spare of ejaculation and a spare of their sex life. So I want to thank everybody once again. My name is Dr Greenstein. I am a urologist here with Advanced Urology. I put my number up on the slide here. So if there's any questions, please don't be afraid to reach out to us. And I hope you have a good night. Thank you.